Okay, so these are my disclosures. When it comes to treat ICAD or an acute endovascular treatment, the problem is we do have many tools. Not all the tools work for all strokes. So, so this is the message. However, at least I speak for myself, but probably for many of you, when we do start a case, if we are aspirator believers, stent reavers, or whatever, we always start with the same technique, at least myself. And this is an extreme case, and that should make us think. This case is from 2017, and if I would have paid more attention to, not much more attention, but a little bit of attention to the baseline CT scan, I could see this calcified lesion. So what was I thinking when I thought I could do a good job with a stent reaver? Probably now it's obvious to me that this will not work. Anyway, this is what I did. And in the baseline angiogram, you can already see that there's already something going on there. Despite that, I did a first pass. And at that point, again, listen, you see there's a high-grade stenosis, and probably it's not a good idea to go there again with a stent reaver. Well, I did 2-3 passes. I started getting more, doing more crazy thing, two stent reavers here. I start getting some, I don't know, advances or going backwards because I start getting some stuff out. Then pass number 4, again, the artery was always dirty there. More stuff coming out, and finally reocclusion. And after 6 passes, I thought maybe it's time to change, and I should probably have done that way before, right? So obviously, if you change your strategy after 6 passes and you place a stent with an angioplasty and start doing antiplatelets, it's not strange that you get this result with a fatal, dramatic outcome, right? So this is what we shouldn't do. We all heard about the first pass effect. Of course, this should be the goal, but there is an additional harm or damage for each additional pass, right? So we should aim, of course, for the first pass. We should aim for recanalization, because either, despite that, recanalization with 5 or more passes is better than non-recanalization. But at some point, we should think about other strategies. So it can be balloon-mounted stents or self-expandable stents. In this recent study, they achieved with balloon-mounted stents, which is kind of my preferred strategy, but they achieved a 93% rate of recanalization. And despite that, the rate of good outcome is not so good. And why is that? Well, no wonder, right? And the authors say that they didn't place the balloon on the first pass. They always went or thought about it when everything else failed, right? So when should we suspect an ICAD? Probably before the first pass. And when should we switch to a different technique, an angioplasty or stenting? So if you achieve complete recanalization with balloon or with a stent after 5-6 passes, well, your rate of good outcome obviously is not going to be as good as if you would have chose to angioplasty initially and get a recanalization at first or second pass. So, well, here's the challenge, no? How can we select the appropriate patient for the appropriate technique? We can gather some information from the baseline CT scan, as I showed initially, in some cases, or we can gather information from first angiogram also. We have different profiles. Like here, obviously, you can see a big clot sitting here. So, for example, in this publication, they defined regular and irregular cutoffs in the angiogram, and overall, for all subgroups, irregular has always tends to be a worse outcome. However, when you check and you look for patients in which first line was stent retriever or first line was aspiration, you see that if you had a regular cutoff point, you could benefit more from initial aspiration, and on the other hand, if it was irregular, the results points that you should choose stent retriever as an initial technique. So, what happens in this case? So this doesn't apply neither for irregular or for regular, and maybe I thought that could be stenosis. This is the baseline angiogram. After going there with the guide wire only, I could open a little channel. I believe this is an ICAD, and if you go primarily do an angioplasty and a stent, we got great results. This is only one case, but we should think that why not doing an angioplasty primarily as our first attempt. Anyway, so we can have different examples. We have to somehow related to the nature of the occluding clot. We can gather some information from, and I think we don't use it enough, intraprocedural con-beam CTAs. Like in these examples, those are not acute cases, but this DSA may look quite normal. Even the 3D rotational doesn't look so bad. But if you do a con-beam CTA, you start seeing that there is an intraluminal filling defect. If you dilute the contrast, you will see different things. And if you combine diluted and non-diluted, you might see that there is a plaque with overlying thrombus. So we can gather information. Again, here, DSA looks you can only see a stenosis. On the con-beam, you see that there might be some kind of dissection there. And even after angioplasty, if you do, again, a con-beam CTA, you can see a dissection that you could not see there with the normal DSA. So this is a source of information that we are not using enough. And also, we have more technology coming. We might be able soon to get information directly from a guide wire. And so this is a prototype from a guide wire that is being developed in France, in which they applied these sensors in the tip of the 014 guide wire that connects remotely wirelessly with a handheld device, a screen. And you can see in this video how, and can you play the video, please? Yeah. We have a red and white clot, and while the sensor is in touch with the clot and crossing the clot, you see completely different signals, and this is could be a great source of information about the nature of the clot. So, well, to summarize and to finish, I think we should use all our weapons, devices, according to the information that we have. We should not follow always the same initial treatment, and try to explore ways to get information about who is our enemy and how we can best attack it. Thank you very much.